Welcome to Farm 533, the renal module on chronic kidney disease. My name is Carly, and this is my first time facilitating a U of A course, so bear with me. I have created a few additional slides to augment the presentation already created by the previous subject matter expert, Katie Habrecht. Since I will be facilitating the course this year, I thought I should introduce myself. I am a University of Saskatchewan grad that completed my pharmacy residency in Saskatoon following graduation in a year that shall not be named. I have been a pharmacist with AHS for the past 16 years, most of which has been in nephrology and transplant. I worked for 12 years on the inpatient nephrology unit at Foothills Medical Center and subsequently moved to my current position in the glomerulonephritis clinic as an ambulatory pharmacist and have been here for 4 years. After reviewing Katie's slides, I wanted to touch on a couple additional points of emphasis to keep in mind when managing a chronic kidney disease patient. A lot of what we are managing in patients with chronic kidney disease is risk. We are trying to predict and manage the risk of progression of the disease itself, while at the same time we are trying to evaluate the additional risk that chronic kidney disease confers to the average patient in terms of cardiovascular disease. As Katie mentioned, there are a number of complications of chronic kidney disease. The one that I will touch on quickly is metabolic disturbances. And while diabetes has already been covered as a topic in a previous course, we should touch on, at least briefly, the subject, as it is one of the main contributors to the cause and progression of chronic kidney disease. Chronic kidney disease risk. In your required readings, you would have already reviewed the KDIGO guidelines and have seen the heat map for prognosis of CKD. As you can see, this heat map was developed to help define risk in CKD, specifically taking into account both GFR and proteinuria or albuminuria. Prior to the development of these guidelines, CKD was purely defined by GFR alone. Proteinuria has been highlighted in the last approximately 10 years as a significant contributor to progression of disease and therefore stratifies CKD further when combined with GFR. As you can see, those with progression of CKD below a GFR of 30 mils per minute, and with protein or albuminuria greater than approximately 300 milligrams per day, risk significantly increases and closer monitoring is required. Risk of progression is very useful in defining the amount of monitoring that is required for those with CKD. The kidney failure risk equation was developed in Manitoba in 2011 and has now been widely used for CKD programs to help limit wait lists for management of CKD and to help define those patients that have the highest risk and who would benefit the most from nephrology or transplant multidisciplinary care versus those that are at lower risk and that could be managed by GPs or in primary care in the community. I have attached a link to the website to this calculator and included references for its use in the additional readings list. Please take a look and plug in some numbers to evaluate different patients' risks based on their numbers. We will also use this calculator in our patient case. Katie has already stressed the complications of chronic kidney disease, including the fact that CKD is associated with a significant increase in cardiovascular mortality than those without the disease. When we manage patients with this disease, we must ensure that our goals of therapy include taking this risk into account and managing this risk with appropriate therapy. This includes statin use, as well as ensuring that both blood pressure and hemoglobin A1C targets are met in those with concurrent hypertension and diabetes. I want to highlight a website that has been developed to manage some of the issues in patients with CKD. The CKD pathway at www.ckdpathway.ca was developed by our Calgary group, including Dr. Brenda Hemmelgarn, and has become a great reference for managing CKD in the community. Please have a look at the website, as you may find it to be a great reference to manage your patients in the future. There are a number of great references, including renal dosing, that I have been involved with and is just being updated, as well as dietary information and other links that can be useful in managing patients with chronic kidney disease. As I have already stressed, CKD comes along with a number of competing risks. CKD has been classified to have a risk equivalent to that of coronary artery disease, and statins have been shown to reduce this risk. We will discuss the data behind these findings once we get into the patient case, but we know that early initiation of therapy is important in CKD, as once a patient reaches end-stage renal disease, the benefit of this intervention seems to disappear. Hypertension is another important disease that needs to be managed. Katie already touched on the fact that hypertension is one of the most important factors in disease progression as both a cause and a consequence of CKD. Meeting blood pressure targets is a very important way to reduce risk of progression. We will discuss the specific targets in regards to presence or absence of proteinuria and diabetes when we discuss the case and options that are available to help us manage these targets. We will see that our choice of agent may vary depending on these factors, and that often additional agents are needed other than a first agent to control these blood pressures. Diabetes is the leading cause of kidney failure worldwide and has huge implications in the development and progression of chronic kidney disease. Hemoglobin A1C is another important risk-reducing target in those with diabetes and CKD. You will find that a large number of patients that you manage with CKD have diabetes, either as the cause of their nephropathy, or they have a disease as a comorbidity that requires managing. Specific therapy choices relating to the use in diabetics with CKD are important to identify and utilize as much and as early as possible. We already know that there's an abundance of data in using ACEs and ARBs in this population, but more recently, there has been more robust data for the use of SGLT2 inhibitors for both meeting diabetes targets, but also for preventing progression to end-stage kidney disease. There is emerging data that these medications may even have benefit in some specific populations, even without the presence of diabetes. We will discuss this further in the course. Metabolic abnormalities. As the GFR falls in later stages of CKD, the incidence of metabolic acidosis increases, with about a third of patients with GFRs less than 30 experiencing some level of acidosis. Correction of this abnormality has been shown to help reduce the risk of CKD progression, and medication management with sodium bicarbonate may be necessary. Hyperkalemia is actually relatively uncommon in the normal population, but quite common in those with chronic kidney disease. It continues to increase in incidence as patients move along the continuum of renal disease, with up to 50% of patients experiencing hyperkalemia in stage 5 kidney disease. Often the cause is multifactorial, with both the gut and the kidney functioning to maintain homeostasis, but reduced potassium excretion and use of medications that induce hyperkalemia are regular contributors. We know that elevated potassium levels are associated with morbidity and mortality, and that monitoring and treating this complication is an important part of CKD management. We will discuss the options for treatment further in this course, but of note there are 2 new agents on the market just in the last 3 months to treat hyperkalemia to replace the older options that have been used for years. Anemia. Katie has already touched on this topic in detail, but I would be remiss if I didn't give you a bit of information in regards to emerging therapies in this realm. In the past, we have utilized both darbepoetin and erythropoietin injections along with oral and IV iron for management of anemia, but there has been new data for the HIF inhibitors, or hypoxia-inducible factor prolyl hydroxylase inhibitor, roxadustat. These are oral medications that have recently completed phase 3 trials showing promise in this area as a new option for treatment of CKD and end-stage renal disease-induced anemia. I have included the most recent meta-analysis of these studies for your information, and we will discuss further in the patient case. As you can see, there are many facets involved in managing a patient with CKD. From managing risk to various complications and comorbid diseases, these patients are usually complex. We will discuss in depth many of these concepts and the data behind our decision making. I look forward to future discussions with your class.